Oh, you snuck up on me there. Well, I'm so happy you've arrived here at the CAKE PIE EXPO for our first session of the day. And in fact, our first topic is, what's cooking in cataract? The topics, FLACS is improving by Dr. Harvey Uy out of the Philippines. Yippie Aye Yay, Flanged prolene solutions for complex cataract surgeries is by Dr. Cathleen McCabe out of the United States, a real social media maven too. And finally, Make My Phaco Fly by Dr. Florian Kretz, a notable ophthalmologist out of Germany. Well, let's get cooking!
Hello, I'm Dr. Harvey Uy from the Peregrine Eye and Laser Institute in the Philippines, and it's a pleasure to talk about the continuing evolution of femtosecond laser-assisted cataract surgery, or FLACS. I do receive research funding from LENSAR. Over the next few minutes, we'll review the basic functions of FLACS lasers, as well as some advances with this technology. Femtosecond lasers were introduced about a decade ago to facilitate the essential steps of cataract surgery, such as anterior capsulorhexis, lens fragmentation, and clear corneal incisions. The capsulorhexis creates an opening for nuclear disassembly and allows IOL implantation. Capsulotomy size, shape, and centration is very important because a well-constructed capsulotomy increases the chances of effective lens position and improves the predictability of refractive outcomes. Capsulorhexis, of course, can be done manually, but manual capsulorhexis tend to be less consistent in its parameters, and if we make them too small or too large, we can get malpositioning of the intraocular lenses. Recognizing the importance of a well-constructed capsulotomy, several companies have introduced innovative technologies. On the left, you can see the selective laser-assisted system, wherein a laser mounted on the operating microscope will fire and photocoagulate trypan-coated anterior capsule to create a nice round rhexis of a predetermined size. Another interesting device is the Zepto Pulse Precision, which is a device containing a wire that is placed on the anterior capsule. And when you run an electric current through that wire, the wire will cut a round capsular rhexis. And femtosecond lasers have actually been around for more than a decade, and everyone is familiar with how the laser can create a predetermined, well-centered capsular rhexis of the appropriate size. What's the benefit of a well-centered laser capsulotomy? Dr. Zoltan Nagy from Hungary has demonstrated that if you have a laser-cut capsular rhexis, there's more chances of good effective lens position without dislocation of the intraocular lens. So you get better refractive outcomes. Our own experience over the past 10 years shows that when we use FLACS capsular rhexis, we get more predictable refractive outcomes because the lens has a very good effective lens position. What's new in FLACS capsulotomy? We're excited because now the FLACS laser can actually create these toric IOL alignment marks, which we call refractive capsular rhexis marks on the anterior capsule. And we're also exploring the ability of free-floating laser-cut capsulotomy buttons to protect the corneal endothelium for eyes with endothelial dystrophy. So this video shows you the endocapsular protection technique. So this is a patient with mild to moderate Fuchs endothelial dystrophy. And what we want to do is to protect the endothelium during the surgery using the laser-cut capsular rhexis. So we begin by coating the endothelium with OVD, typically Viscoat, and then we place the cannula just beneath the anterior capsule, and by injecting OVD, we can float up that anterior capsule almost till it reaches the endothelium. So this now serves as a shield so that when you're doing the phaco emulsification, lens fragments, ultrasonic energy, and turbulence caused by fluid movement will not damage the corneal endothelium. You can see that you can preserve the capsular button until after the nuclear disassembly, and normally we would then remove this during the I&A. So with this built-in shield, we can protect the corneal endothelium and actually minimize damage to it and increase the chances of having a clear cornea the next day. Now let's talk about laser lens fragmentation, which has the goal of softening the lens to facilitate nuclear disassembly. So we've demonstrated in the past that the type of lens fragmentation pattern will influence the total amount of energy used for this phaco emulsification. The more extensive your treatment pattern is using the FLACS laser, the more lens softening and the less ultrasonic energy and phaco time needed to disassemble the nucleus. So different FLACS lasers now have their own adjustable treatment patterns. For example, in the catalyst system, you can decrease the space between the laser shots. You can change the grid spacing. So if you have a harder cataract, you make the grid spacing smaller so that you'll fire more laser to soften the lens nucleus more extensively. In the LensR system, the high-resolution scanning will actually give you an image of where the nucleus is, determine the extent of the hard nucleus, and then automatically adjust the laser treatment to focus on that hard part. And it will also select the appropriate treatment pattern to soften that hard nucleus. So for example, for category 3 very hard nucleus, the laser will use a pie cut fragmentation pattern. So when you can customize the treatment according to the lens nucleus, you can decrease the energy needed to phaco emulsify the nucleus. And this results in reduction of endothelial cell loss, facilitating recovery of the cornea after the surgery. Let's now talk about the clear corneal incisions made by the FLACS laser. So these clear corneal incisions allow access to the inside of the eye for surgery. And we know that ideally we should be making a multi-plane or three-plane type of incision so that the wound will seal better. If we use the manual keratome, sometimes we may achieve this, but studies have shown that very often you don't wind up with a three-plane incision. Usually you'll wind up with a biplanar or even uniplanar incision. But when you use a FLACS laser, the laser will consistently create this very nice multiplanar incision, which actually seals shut more often than not at the end of the surgery. So when you get a good wound seal, and you don't need to rehydrate or reform the anterior chamber, and you get more stable IOL within the capsular bag. One of the exciting developments in FLACS technology is the ability of new software and new equipment to help the surgeon improve refractive cataract surgery outcomes. We recognize that astigmatism is a major cause of unhappiness after cataract surgery, and about a third to half of the population will have significant astigmatism, which, if not corrected, results in a degradation of the quality of vision, especially if you put in a premium IOL. There are several ways to decrease astigmatism. Incisional corrections, such as limbo-relaxing incisions, are easy to do, but often you get inconsistent results. Toric IOLs are more consistent in decreasing astigmatism, but demand precise axis alignment to get the best outcomes. So how can FLACS lasers help us reduce astigmatism? There are two ways. The FLACS laser can create a more consistent arcuate incision or astigmatic keratotomy, consistent in terms of the incisional parameters. So you always get a consistent depth, a consistent length, and consistent distance from the limbus. The other way FLACS lasers help us treat astigmatism is by creating these toric IOL alignment marks so that we can put the IOL in the optimal position to maximize reduction of astigmatism. Okay, so The FLACS lasers can now import topography data from the corneal topographer into the computer of the FLACS lasers. We know that this is being done with Catalyst, with Zemer, with Lensex, and also with LENSAR. The LENSAR system does two other things. It takes a picture of the iris before and during the surgery, determines whether there's cyclotorsion, and compensates for this. This video will demonstrate that. So here you can see that the eye is under the laser, and the machine software will take a picture of the peripheral iris and compare it with the preoperative reference image taken by the topographer, and then it determines if there's cyclotorsion and adjusts the location of the arcuate incision to account for that astigmatism. So this adds an extra level of precision to this procedure. I usually tend to open these arcuate incisions to get a greater effect. And we've shown that by doing FLACS astigmatic keratotomy, we can significantly decrease the amount of expected refractive astigmatism after surgery, generally with no additional cost to patients. You don't have to spend on a toric IOL or these mild levels of astigmatism. For greater amounts of astigmatism, toric IOLs will correct a greater amount, but they have to be placed optimally along the correct axis. And we've evolved from using ink-based systems to digital markerless systems to wavefront aberrometers to help guide us place the toric IOL in the correct position. These technologies have their own pros and cons. When we're using the FLACS laser, we can use the FLACS laser to create these toric alignment marks either on the cornea or on the anterior capsule. You can see the anterior capsular mark here. It's like a nub on the anterior capsule. And preclinical studies have shown that these marks don't affect the strength of the capsulorhexis. We call this process refractive capsulorhexis. And this video will demonstrate this. So here we have a patient with astigmatism, and similar to astigmatic keratotomy, the laser recognizes that there's cyclotorsion and subsequently adjusts the position of the refractive capsulorhexis marks to adjust for that cyclotorsion so that you can place the toric IOL more accurately. So then we bring the patient to the operating room, and you can clearly see these capsulorhexis marks under the surgical microscope. So at the end of the nuclear disassembly, these marks are very clearly seen, and usually they would align with the digital marking system. So all the surgeon has to do is to put the toric IOL in the capsular bag and align it with the capsular marks. And we've, in our own unpublished series, we've shown that you get a more reduction of astigmatism and better outcomes when you follow these refractive capsulorhexis marks compared to digital marking systems. So following this, using toric IOLs, we've gotten a very nice reduction of astigmatism, very consistent outcomes. The group of Denise Visco showed that you get better refractive outcomes following these refractive capsulorhexis marks compared to using ink-based marking. Finally, one of the most exciting features is combining FLACS laser machines with Phaco machines in order to improve workflow efficiency. So in our previous setup, we would put the patient on the operating bed and wheel them under the femtosecond laser, do the femto treatment, and then wheel the patient to the Phaco area and do the Phaco emulsification there. So wouldn't it be great if you could integrate the Phaco machine with the femto machine so that you only have one machine with a smaller footprint? This would free up a lot of space, and it will save you time because you can just put the patient in one position and not have to move the patient. So this is basically what the LENSAR Ally system does. It incorporates a Swiss Ortli machine into the LENSAR machine. Somehow they're able to shrink the footprint of this, put in a faster laser system so that the laser procedure takes less time. And you also save time because in this system, the patient doesn't have to transfer anymore to another area for the phaco emulsification. You just have to deploy the phaco instruments from the machine and do the patient's phaco without having to move. So this is, I think, one of the best-in-class strategies to increase workflow efficiency in the operating room. So think about it. You can do the different steps of the cataract surgery using different instruments, or you can use one instrument to do most of these functions, including the astigmatism correction and the phaco emulsification. So this actually will save you a lot of time and effort and make the workflow in the operating room more efficient. So in summary, the FLACS lasers continue to facilitate cataract surgery. They continue to help do the essential portions of the cataract surgery. Now with the integration of topographic data and computer-guided astigmatism correction software, we get better outcomes for correcting astigmatism. Some of these lasers also can make corneal pockets. For example, the Zimmer can make pockets and flaps to facilitate refractive surgery, further improving the multifunctionality of FLACS lasers. And finally, by integrating the phaco machine, we can integrate workflow efficiency and possibly improve the sterility of the process. So let's view FLACS lasers as multifunctional tools that can help us get the best out of our operating theaters. Thank you very much for your kind attention.
Well, that was a great presentation by Dr. Harvey Uy. Harvey is one of our great advisory board members for CAKE magazine, always willing to participate. And next up, we have Dr. Cathleen McCabe, who joins us with a great costume on. Let's get right into her presentation.
Hi, I'm Dr. Cathleen McCabe, and I'm delighted to be at the CAKE PIE EXPO, sharing with you Yippie Aye Yay, Flanged prolene solutions for complex cataract surgeries. These are my financial disclosures. None of them are relevant to this talk. And there are many reasons that we are seeing an increasing number of in-the-back IOL dislocations. There are patients with pseudoexfoliation, prior eye surgery, such as vitrectomies, axial myopia, eye rubbing, trauma, capsular phimosis, and complicated primary cataract surgeries. And there's been a lot of innovation in how we can treat these patients. One of those most important innovations has been that of Shin Yamane, who showed us how to externalize a haptic of a three-piece lens, preferably those with prolene haptics, such as a Lucia lens from Zeiss. And then the externalized haptic is treated with low temperature cautery, creating a front flange that is then positioned in the superficial layers of the sclera and supports the three-piece IOL very well in the case of no capsular support. And because of these flanges and the idea of using prolene, there's been innovation using just prolene suture itself. And Sergio Canabrava published some of the earliest work on that, looking at the eyelet of a CZ70BD to begin with, where that was threaded with a 5-0 prolene suture, and that was secured by creating a flange on one end, and then externalizing the opposite end of the suture through sclera and conjunctiva in the sulcus, and then creating a second flange. He also published a paper looking at a series of AO60 closed loop haptic 4-point fixation, and there have even been some innovations in IOL design. Dr. Canabrava has one, and then there's another shown here from India. Around the same time, I looked at the use of prolene suture as I learned about it in helping with a wet lab around learning the Yamane technique, and theorized that I could pass that around a haptic through the capsule in an in-the-bag dislocation, and then through the sulcus and out again, creating flanges and supporting in-the-bag dislocations without an IOL exchange. And this technique's been used for many different IOL types. And here you can see Tim Page is using it to thread through the eyelet of a toric plate haptic lens, keeping that in the axis needed for correction of the patient's astigmatism and allowing them to retain their original lens. And that's what worked very well in this case. We're going to talk more about the belt loop technique, but another innovation has been that of Dr. Micheletti in conjunction with Diamatrix, where a small punch was created to create a perforation near the optic-haptic junction, especially in single-piece acrylic lenses where a prolene suture can be passed, flange created that then holds on to the IOL, and that's passed through the sulcus, through sclera and conjunctiva, creating a flange on the outside of the eye that can support the eye. Another way of doing this is to pass a needle through the optic at the optic-haptic junction, or in this case, piercing the haptic with a needle and then threading prolene into that. And this can be a nice way of also securing the lens. This has recently been published by Dr. Carvalho, who showed some very nice videos demonstrating this technique. It's really important to be sure that you are piercing the haptic at the same location along the haptic in the same orientation in order to get nice orientation without a tilt or decentration. All of these techniques require two securing points to be 180 degrees apart if you're using that. Another innovative technique is to elongate a haptic, in this case by creating a smaller bulb on the end of a prolene suture that's perforated with a 30 gauge needle, threaded onto a haptic. A flange is created, and this elongates the haptic and allows for more flexibility in externalizing and creating that support system. So we're going to talk a little bit more about the fibroprolene belt loop. Here's another illustration of that, going from sclera around and the haptic through the capsular bag, back out through sclera. This is actually the first patient that I treated who had a multifocal lens, and she was really very willing to try something innovative in order for her to keep her lens, and really wanted to do something that maybe had a longer term life than a 9.0 prolene suture. So I'm going to mark 2 millimeters posterior to the limbus, and I'll pass a 27 gauge needle in this case, 2 millimeters posterior limbus underneath the haptic through the capsular bag. And it's helpful to have a microforceps to assist with this maneuver. And then I'm going to pass the cut end of a piece of fibroprolene that's cut at a bevel into the lumen of the needle. And then that will be externalized through sclera and conjunctiva. And then when it is externalized, that'll be trimmed and a flange melted with low temperature cautery. The second needle was passed just anterior, closer to the limbus, about a 0.5 millimeter, and then anterior to the capsular bag and haptic through the sulcus. And then that similarly is withdrawn, and the suture is melted into a flange, which is buried into the superficial layers of the sclera, covered with conjunctiva, making sure that it's flush with the surface of the eye so it has less chance of eroding in the future. This is a very secure way. You can see that that lens is not moving at all and was able to achieve very nice centration with no tilt. This is the patient looking down. You don't see the belt loop, but you do see those flanges underneath the conjunctiva. And this patient was very happy to retain her premium lens. This is a more recent case, and I've now changed to using 6.0 prolene with a thin-walled TSK needle. Just results in a smaller flange, and there's a smaller opening with the TSK needle as well. And that allows for a little bit easier burying of the flange into the superficial layers of the sclera. So I have again cut the section of 6.0 prolene at a bevel. You can see that just makes it easier to introduce into the lumen of the needle. That needle has passed posterior to the limbus about 2 millimeters, and it is passing underneath the haptic through the capsular bag. I'm threading that 6.0 prolene into the lumen of the needle until it stops at the bend of the needle. Then I'll withdraw it and grab it at the surface of the conjunctiva and make a small flange there, just kind of a safety flange at this point, so that I have time to work on passing that second needle, which will go anterior to the capsular bag and haptic. And this is really a pretty small pupil, but you can see with the assistance of either a cannula or even a second micro forceps that you can see where you're passing the needle adequately, and you really don't have to put any pupil expanders in. This is the other end of that cut piece of 6.0 prolene suture being externalized after passing through the sulcus anterior to the lens bag complex. I'll trim that, create another flange, leave these kind of long because I know that I'm going to be placing a second belt loop around the other haptic since this was more severely dislocated, and externalizing that, making sure that it is placed 180 degrees to the first belt loop. And again, a micro forcep to manipulate the edge of the iris is very helpful in visualizing, making sure that you're near the optic-haptic junction, but underneath the haptic and through the capsular bag. Once you visualize the needle and the pupil, you can let go of the iris and take that piece of prolene that's been previously placed in the anterior chamber, grasping that and introducing it into the lumen of the needle. Much easier if you cut it at a bevel and place the suture into the anterior chamber before you pass the needle. And then one can advance a no further, you can withdraw the needle and externalize the suture. And this is the second pass where it is through the sulcus, anterior to the IOL capsular bag, and completing the belt loop around the second haptic. And then you can just pull on either side, adjusting the tension on both belt loops so that you have good centration, and you also have elevated the IOL so that it's not fallen back further, and the refractive ability and predictability of the result is more reliable because the lens is at the plane of the sulcus. So a small flange is created. You're going to bury that into the superficial layers of the sclera. You can see that that's easier to do in this case with a small flange. I'm taking up any slack, and sometimes you'll trim these a couple of times to get the right tension, creating that very small flange, burying it into the superficial layers of the sclera, covering with conjunctiva, making sure that it's nice and flat by running an instrument over that, and now removing with bimanual INA. Very small incisions are all that's required here. And you have a very, very nice result with an extremely stable lens. So what's needed for the belt loop technique is a 5.0 or 6.0 prolene. Doesn't really matter what needle's on there since I'm going to cut that off anyway. A 27 gauge needle or 30 gauge TSK thin wall needle in order to pass through the conjunctiva and sclera and engage and be fed the prolene suture in order to externalize it. And then low temperature handheld cautery creates the flange. Intraocular forceps are very helpful. It's really appropriate for any lens type. I've used it for all of these: single piece acrylic, plate haptic lenses, 3-piece multifocals, EUF lenses. They can have a CTR or not, and it avoids the need for vitrectomy and an IOL exchange in most of these cases. So there are other ways of using phacoprolene with phalanges, including iridodialysis repair, either with a single pass or multiple single passes, or even the sewing machine technique, which is similar to that that's been used with smaller gauge suture, but it works very well this way as well. And then those loops, after externalizing them, are cut and flanges are created, and that can result in repair of a larger or broader iridodialysis. This is another place I think it really helps, and that's in severe zonulopathy. On the left here is a case that I presented a few years ago where it was a very dense cataract, small pupil, so we weren't really sure there was this severe level of zonulopathy ahead of time, but I placed a pupil expander. In this case, it's a nitinol ring with these pockets. It's created by a company called Diamatrix, and it engages the margin of the pupil, but also those little pockets can engage the margin of the capsular rhexis and support a loose lens. But you can see that the cataract was removed. I placed a CTR. I'm now placing a toric lens. That was the plan for this patient. And I'm going to create a flange, pass the phacoprolene through the eyelet of an OMED segment. I'm placing that in the meridian of greatest zonular laxity. And because I need to access the sulcus in order to pass the trailing end of the phacoprolene into a needle, placed through the conjunctiva and sclera into a sulcus, I'm going to disengage that pupil expander in that margin while this is occurring. And now I'm going to also put support on the opposite side, since this really was a generalized severe zonulopathy, and just doing the same exact thing, placing the needle through conjunctiva and sclera, 1.5 to 2 millimeters posterior to the limbus, very symmetrically, 180 degrees apart, creating phalanges through the eyelet of the OMED segment prior to placement, and then at the surface, and burying those phalanges into the superficial layers of the sclera. On the right, utilizing a similar technique, Tama Oding supported a lens, actually an intraocular lens, after removal of the cataract in the case of, again, severe zonulopathy. You can see he's already placed a CTR. The cataract's already been removed. And he chose to leave the needle on the fibrocromine, pass it through a groove in the sclera into the sulcus, and then retrieve the cut end of the fibrocromine, create a flange after passing this end, this cut end of the fibrocromine through the eyelet of an OMID segment. So both of these techniques shown here, we're placing the OMID segments with fibroflange prolene suture, but after the cataract was removed and a CTR was placed. And this is a really great way of addressing that. But more recently, I had this patient, again with severe zonulopathy, who you can see here, you can see the margin of their cataract and that scalloped edge that indicates there's very few, if any, zonules in that area. And I know I'm going to need some capsular support there, so I've already pre-placed a piece of prolene, fibrocromine through the eyelet of an OMID segment, creating a flange. You can see as I'm removing that central capsule after a femtosecond capsulotomy, a lot of movement of the lens. There's really nothing supporting it for 180 degrees there. I've placed the TSK needle, thin wall 30 gauge needle, through conjunctiva and sclera into the sulcus, 2 millimeters posterior to the limbus, and then threaded the cut end of that fibroprolene that's through the eyelet of the OMID segment into the needle, externalized it, and now I'm placing the OMID segment into the capsular bag, cinching it up some so that it can support the capsular bag during removal of the cataract. I've also placed capsular hooks 180 degrees away so that I don't damage any of the zonules that appear to still be holding the cataract and capsular bag up on that margin of the capsule. And I'm very carefully placing a CTR using a Sinskey hook so that there's no additional traction on the capsule at the equator. This results in a very atraumatic way to introduce a CTR. I'll remove one of the capsular hooks. I've kept one in place for now. I'm introducing a single piece acrylic lens. I did use this lens because it has those 4 closed loop haptics. If I need to do some additional support in the future, that's a nice way to be able to do that. There were some strands of vitreous that had come around the margin of the lens, and so I removed those with a vitrector and also added additional triamcinolone to make sure that the interchamber was clear of vitreous. So that worked very well in this case as well. So there are complications that can happen with this technique. You can have decentration and tilt, especially if you're not symmetric in how you're supporting the lens. There can be damage to the IOL, especially with a needle pass. You could have late erosion of a flange through conjunctiva, and that is why it's so important to be sure that you're burying the flange well into the superficial layers of sclera and that it is flush with the surface of the eye. This is a report of a case of endophthalmitis after erosion with this type of sutured flange technique, and it has been reported also with the Yamane technique. So in conclusion, 5-0-6-0 prolene with a flange for scleral fixation allows for the original IOL to be fixated securely, and this is particularly important in premium lenses where patients may want to retain that lens. It also can support a secondary IOL. It's minimally disruptive to the conjunctiva, especially in cases where you're trying to preserve it, like prior to trabeculectomies. Small incisions are possible. You may avoid an anterior vitrectomy because no IOL exchange is needed in some cases. It's also useful for other problems such as iridodialysis or severely loose zonules at the time of virginal cataract extraction. It's a low-tech solution. It's accessible to everyone. And most people have low temperature cautery, doesn't require any special tools or tricks, and the suture is readily available as well. And that burying the flange into the superficial sclera is key to preventing erosion and more serious complications. So thank you very much for your attention. Yippie Aye Yay.
Love that outfit, Kathleen. Well, next up, we have Make My Phaco Fly by Dr. Florian Kretz. Florian's a great friend over in Germany, and let's get right into his presentation.
Hello, everybody. My name is Florian Kretz. I'm the CEO, shareholder and founder of Precise Vision, Augenärzte in Rheine, Graven, Steinfurt and Erlangen, and it's a pleasure for me talking about Make My Phaco Fly for CAKE PIE EXPO. Here are my financial disclosures. So talking about making my Phaco fly is actually not that easy, because there are several interpretations, and here you can see my personal ones. And I actually found two. On the one hand, I had tips and tricks for my challenging cases, and on the second one, traveling with my Phaco machine. So first I'm going to talk about tips and tricks for my challenging cases. I guess safety first is always a good one for cataract surgery, and so I'm just going to show some simple ways for intraoperative lens dissection. I do like using several devices in my OR. You can see here Zepto for the capsulotomy. It's very simple, gives you a very size capsulotomy, especially in like small pupils, difficult cases. I really like it. And here you can see the use of MyLoop in a classical way with a two-hand approach. You open the swing, you swing it around the nucleus, you take a second instrument to stabilize the nucleus in the bag, and you make one cut. And I like using the chopper anyways, so I can use it straight away to rotate it, and then you open the sling again, swing the sling around the nucleus, give it a second cut, and you have 4 free floating segments that are easy to remove by Phaco. And you can see it's a small pupil. I'm not using any iris hooks, any Malugni ring, and it works perfectly fine. Just polish the bag. I like bimanual IA to polish. And it makes it very simple, very smooth and very straightforward. And here I implant a one-piece aspheric Rayner lens preloaded, and the case is done. So those toys like Zepto, MyLoop can make a complicated surgery pretty simple. Here you can see a different approach for the MyLoop device. It's irrigation assisted, so I use my bimanual irrigation handpiece to stabilize the anterior chamber. That's also what I do now if I use MyLoop. And you enter with the MyLoop inside the eye, open the sling inside the capsular bag, and this is like the normal speed. And you can see the hand movement on the left. And then once the sling is opened completely, you can swing the nitinol ring around the nucleus, and that will also shave the epinucleus and the cortex from the capsular bag. And you have to swing it all the way around, go back to the middle, and then you just give it a nice and clear cut. And you can use the irrigation port, or you can use the MyLoop tip to rotate the lens in the next position. And just like before, you open the sling, swing the nitinol ring around the nucleus. Also, even with the second swing, I like to go a little bit over the middle, so I know that also the cortical remnants are loosened from the capsular bag. And here you can see the nitinol ring coming around. Go back to the middle and give it your second cut. So very simple, very straightforward, to give you 4 quadrants that you can remove later on. And personally, I just feel with the irrigation in the anterior chamber, I have more control. I'm sure everybody for you is familiar with Breaking Bad, and Breaking Bad for every Phaco surgeon has a special meaning, so I'm going to show you my Breaking Bad case. And you can see here a really hard nucleus, and I don't have a MyLoop, I don't have a femto, and all I do is I have a bent Phaco tip that I dig into the center of the nucleus to go deep, and I use a long chopper to go around the lens, go deep, and just break it in a regular chop and stop way against my Phaco needle. And that technique also works very well with, at least from my feeling, not too much stress on the zonals. And it's a cheaper option than using the MyLoop, and it's definitely like a good way in breaking a bad and hard nucleus. So I spoke a little bit about my tips for challenging cases, but making my Phaco fly also for me has a very special meaning by really flying with my Phaco. And you can see here my good buddy Wolle. Wolle works for Oertli in Germany. And you see him here entering the OR with this little pilot suitcase and like his little plastic bag. And the video on the right is starting already, so everybody can imagine what could be in that pilot case that he's bringing in the OR right now. It's like before the surgeries in the morning, he just arrived that day. And look at that, in there is everything you need to install an Oertli Cataract 3, a highly transportable Phaco machine that fits in a pilot suitcase. And like you all just saw, it's very easy to build together. Here is your clip to adapt it to the infusion stand. You saw before how he put it on. And on the right you can see how he's already installing the Phaco pack. We use a day pack that is licensed for 6 procedures in Germany. So it comes with 1 Phaco pack and 6 pipings. And that makes the whole system very cost effective. The only negative part is because you don't have your own infusion stand, you have to adapt the bottle height manually, but to be honest, that is not really a big issue, and it works very well in our hands. And it's a fun toy for a Phaco surgeon to have a portable Phaco machine, because think about all those options that it offers you. So you can see him setting it up. You can see him connecting it for the first surgery, and there's not much more to show on this picture. But I think what is important to show, we actually used that machine for a whole day long, doing all our regular cases. And, if you would see it like this, you would not think that this little Phaco machine just came out of a pilot suitcase and was just built in together a couple minutes before. And at the end of the day, you can see here my head of staff in the OR, Michaela, and that's the equipment that we used on that morning with this little Oertli Phaco machine. So the performance was good. It was around lunchtime and everybody was done. We're cleaning up. The nurses are cleaning up the rest of the material. And like always, Wolfgang has to clean up his little Cataract 3. So he takes the piping, he clips it out. You can see here the infusion bag that you can also empty in between if it gets too full. And it all goes in the garbage bin. And the infusion bin goes in, the bag goes in the garbage bin, and that's basically it. So the Cataract 3 is ready to be unbuilt. Cables have to be taken off and stored away. And here you see it hanging. Electricity is off already. He packs the cable in the pilot suitcase, unscrews it from the infusion stand, takes the clip off, and everything can be put back in that little pilot suitcase. And that's where our journey continues. So here you can see me now having the pilot suitcase, and there's Wolfgang and I in front of the my clinic in Graven, where the surgeries once a week, with the Phaco hand pieces that we used and with the Phaco machine in the pilot suitcase. And we transported it that day to my second facility in Rheine. You can see here now my head of staff, Michaela, switching on the Phaco machine. And if you just compare it with the picture on the left and you see the Stellaris Elite compared to it, there's quite a big difference in size. So that's our day 2, different facility, again early in the morning. They saw it once how to install the Phaco machine, and so now they are doing it all themselves, preparing it for the surgeries of the day. And even here you would think it's like a high-tech OR with Lumera 700, Callisto, Stellaris Elite and everything. The performance of the Cataract 3, even as a simple peristaltic Phaco machine, was great with that setup. So we did approximately the same amount of cases there, and you can see me loading the Phaco machine in the trunk of my car, but you can also see there's suitcases standing there now, and they're actually not for the Phaco, they were for us, because we traveled with this to the airport in Münster, and I didn't even check in my Phaco machine. I actually went through with it as hand luggage and took it in the airplane, and guess what, that pilot's suitcase really fits in the overhead bin. So that's how I transported my Phaco machine to Erlangen. We landed in Nuremberg, got another car, placed all our stuff, including the pilot's suitcase, on the back of the car, and drove in the hotel. And now that's the next morning in my surgical facility in Erlangen, on our old one at the Waldkrankenhaus, that now we switched to the city center. And this time I built up the Phaco machine on my own, because I was going to use it all day there. And so at all, we traveled with the cataracts from Graven by car to Rheine, from Rheine to Münster by car, then by plane over Munich to Nuremberg, because there is no non-stop flight to Nuremberg directly, by car to Erlangen. And in 3 days, in 3 locations, we performed 100 surgeries with one little Phaco machine in earthly cataracts. And to be honest, that's how you really make my Phaco fly. So thank you very much for your attention. If you have any more questions, if I can help you out any further, just write me, email me, contact me. And thank you very much to CAKE PIE magazine for inviting me, giving my talk. Thank you. Bye-bye.